So we are starting. So I will let Shalia. Did you want me to take over? Or did you want to start with the first few slides? And you're muted if you're wanting to talk.
Give me 1 second, Heather.
Okay, I will do the welcome slide. So, whoops. Welcome everyone to the quarterly First Steps Maternity Support Services MSS and Infant Case Management ICM webinar. This is our welcome screen. Hopefully you can hear me. It sounds like most can. And this is our sound check. And it's going backwards on me. I'm going to work on when Beth, our presenter, starts presenting, I will work on putting in the PDF to have access to the slides for today's webinar. I see that the chat's disabled, so if it's not going to work in the chat, then I will put it into, oh, Stella says she can't see any slides. So let me see something. Let me make sure I've got that on.
Yeah, Heather, it looks like the slides didn't pull up.
Slide stopped. Okay, share screen. Okay, now hopefully you're seeing my screen.
Yes.
I should say downloading files from the webinar. All right.
Yes.
Thank you, Stella. So I will be putting the PDF of the PowerPoint presentation. We've got the two different presentations put into one. So I will be putting that into the chat or the Q&A box so that you can hopefully download that. If not, I will, Shalia or I will be sending out an email probably in about a week with a link to the recording as well as the documents that we will be using. The hand function should be disabled. We are using the question and answer Q&A box, so you should all have access to that. So any questions, please put them in the Q&A box. Beth, who will be presenting this as soon as we're done here, has said that please submit any questions you have and we can interrupt her during the middle of her presentation to ask your questions. So again, welcome to the First Steps Maternity Support Services and Infant Case Management quarterly webinar. And this is the agenda for the webinar today. Beth Tinker with the Healthcare Authority will be presenting on the maternal care model. Then Shalia and I will give some program updates and reminders, answer any questions, and then wrap up. Did you want me to continue with?
Well, hopefully y'all don't hear the baby in the background. So today we are really excited to have Beth Tinker to our presentation. Beth is a clinical nurse consultant, nurse advisor at the Washington State Healthcare Authority. Her nursing experience is in pediatrics, obstetrics, public health, home visiting, and management. She completed her PhD in nursing science at the University of Washington in 2019, where she was awarded the Robert Wood Johnson Scholar Award for doctoral studies. Her research interests include health disparities, infant mental health, protective factors for children and families living in complex adversity, breastfeeding, early intervention, home visiting, and public health nursing. At Healthcare Authority, she focuses on clinical programs and policies across the reproductive health continuum in care for children and families with a focus on perinatal and infant mental health. She is also an affiliate faculty member at the University of Washington School of Nursing. And again, we are so happy and we are so grateful to have you today. So welcome, and we will turn it over to you.
Thank you so much, Shalia. I'm so embarrassed. I remember now that you guys had asked for the bio, but I didn't realize you were gonna read the whole thing. But
it's all good. Yeah, so it works.
It is my pleasure to be here with you all. Thank you for taking your valuable time to join us and your lunchtime, I'm sure. So Heather and Shalia asked me to come and to share information and to gather questions and feedback from you all around the maternal care model. So I appreciate that there has been interest and some questions with my esteemed colleagues here at the Healthcare Authority. And so we just hope to provide some additional context and information, the perspective of you all as MSS ICM providers in this work and in the broader system of care that is really supporting and providing needed services to the population of pregnant, birthing, postpartum people and infants is really critical to our overall work, of course, across the state, and to the maternal care model project in particular. So as Murphy's Law would have it, I'm getting a network instability message on my screen. Is my audio okay, Shalia and Heather?
Yeah, you sound fine to me.
Okay, I might go off video for now while I'm going through the
Yeah,
slides, at least initially, just to avoid any trouble. So I'm sorry for that. I'm happy to come back on later. We'll see how. Okay, so I am going to stop. Okay, thank you, Heather. So here's the agenda for today. If any of you attended the kickoff webinar for the maternal care model, which was the first week in June, there absolutely is some of the same content in this presentation. There's also new content. So I certainly hope for those who attended that this will not be just repetitive, or in other words, not valuable to you. For those of you who did not attend that, I think there will be a lot of new information today. So I'm going to introduce the concept and the development of the maternal care model. I'm going to provide some context around the BRIE, which just seemed helpful, especially given what I heard were some of the questions that were coming in from MSS and ICM providers. A little bit of key considerations for the models, like the goals and targets of the work. I'm going to give a little bit of kind of foundational level setting around value-based purchasing. It is related to this project. It's also very much a term that comes up a lot in terms of payers and purchasers, and certainly the Healthcare Authority. So just want to make sure we're all kind of using the same language and have some baseline kind of understanding. A quick slide on the project timeline, just for everyone's awareness, and then time for feedback and questions. Okay, next slide. And I'll just repeat, I know what was already shared, but questions are super good throughout the presentation, and I've asked my colleagues to feel very free to interrupt me. I will try to pause and not fill all the spaces so that they can do that. So I'm very happy to entertain questions as we go. It's probably easier given there's a lot of information on some of these slides. They're pretty dense, and I certainly want to get to everyone's questions. So please feel free and welcome. Okay, so this is a little bit of kind of the foundational knowledge. The work that the Healthcare Authority currently that we are engaging in on this maternal care model did not kind of come out of nowhere. I mean, it is very much contextual based in terms of our current maternal mortality, particularly our Black and Brown maternal mortality and morbidity crisis. I mean, that is the kind of the overlying driver. But there's been work going on in Washington State for several years around how do we really improve population level health for pregnant, birthing, and postpartum people and their infants. What are the strategies to do so? How do we use payment as a lever to really drive? Kind of the logic model is using payment as a lever to change provider behavior. In this context, when I say provider, I am, for the most part, talking about kind of the primary OB provider. So the clinical OB provider, whether that is a licensed midwife, a certified nurse midwife, a family physician, an OBGYN, a maternal fetal medicine specialist. That's kind of the whole gamut of who primary OB providers are in Washington and that Medicaid pays for. But really looking at using payment as a lever to drive changes in provider behavior, to drive better outcomes for patients. Like that's sort of the foundational rationale behind this model. And so the BRIE Collaborative started working on maternity care as a focal area back in 2019. If folks are not familiar with the BRIE Collaborative, they are legislatively mandated, created back in 2011. The way that they kind of function is the members are appointed actually by the governor who are part of the BRIE Collaborative. They have different subcommittees and focal areas in terms of medical specialties and populations that they focus on. And every year those members identify areas, clinical areas, or episodes that they're going to focus on. How do they decide what to focus on? They have criteria. I mean, I've never been part of the formal process, but I know, for example, they look at, you know, a clinical area or specialty where there's significant variation, right? So we see that, you know, outcomes vary by different demographic factors. We see that care varies, so clinical care is perhaps not consistent. There's not consistent use of evidence-based practices. And then there also has to be a considerable opportunity to improve health by focusing on this area. Just so everyone, like to give a little bit of more context, historically, the BRIE Collaborative has focused on episodes of care that are kind of procedural based. That is not so much the case anymore, but it's really, if you look back in the history of kind of the different areas that the BRIE Collaborative has addressed, we're looking at orthopedic surgeries, we're looking at cardiovascular, you know, like stent procedures. They've looked into bariatric surgery, right? So sort of these clinical episodes. And then what they do is develop recommendations and really how to improve care within those episodes in those time periods. So again, back in 2019, they decided that they were going to work on maternal care or perinatal care. Their overarching goals were to improve the clinical care delivery, decrease any preventable complications, and increase coordination of care. All of these are going to be common themes as we continue to talk today. Of course, these are also common for MSS, right? So there's lots of synergy and kind of overlap there. I included the link here if folks are interested. All of the work of the BRIE Collaborative, I shouldn't say all, but much of the work of the BRIE Collaborative and their outcomes and all these different clinical areas, they're all available on their website. So if it's something that interests you, you can certainly go there and learn a lot more. Okay, next slide. Any questions so far? This, I should pause. Okay. So this slide is just digging a little bit around, okay, so we have some understanding of what the BRIE Collaborative is and what they did. 2019, they decided to focus on perinatal health and a perinatal bundle. So what is that? What does that mean? What is a bundle? It's really an episode-based payment model. Folks also refer to this as a bundled payment for a defined period of care with required evidence-based clinical components, reporting metrics, and an opportunity for gain sharing. Folks also refer to that as like incentive payments or such. So really kind of in the broadest sense, if you think of episode-based payment model or a bundled payment, there's usually kind of three big legs to that stool. One leg is the required clinical care, right? So what are we requiring? Whoever the primary clinical provider is, that's sometimes called the accountable entity or the accountable provider. Like what is the clinical care that we are saying, if you engage with us in this bundled payment model, this episode-based payment model, this is the clinical care that you have to provide. And it can be quite long and detailed, right? But this is, so for OB care, we're talking about you have to provide, you know, routine visits at these different increments. You have to provide these types of screenings, right? You have to provide these types of patient-directed education. You have to use shared decision-making in your clinical practice. Like those are just some examples of what the clinical care components can look like. The second leg of that stool are reporting metrics. So always within a bundle payment or an episode-based payment model, there are required reporting metrics. This is often framed up in terms of the shared accountability, right? So the accountability on the provider side is that the health of the population that they are seeing, of their patient population or their panel, is improving. And the way that we monitor that is via reporting metrics. So reporting metrics are always part of these efforts. Sometimes they are tied to payment. So that is sort of the third leg, which is really the payment model. Payment models can look different. I won't get into details there because it gets super in the weeds, but there's different ways that payment can flow, but payment is kind of always the third leg on that stool. So the Pre-Perinatal Bundle, again, there's a lot. I just pulled out like a few highlights. So in terms of the definition of the timing, like what does it include? What includes all the prenatal care. So we're talking about from initiation of prenatal care through the postpartum period, labor and delivery. So the services right around the time of birth, whether that be a hospital birth or a community birth, right? Which could be a home birth or a birth center birth. The postpartum period in the perinatal bundle is the full 12 months. That wasn't initially part of that work, but as you notice the time frame, Bree started working on this in 2019. Well, during that time, our legislature passed, Senate Bill 5068, which is 12 full months of postpartum coverage, which was just implemented last month in June. And so the Bree they've regathered their team, and they ended up including postpartum care and the model of care for that full year postpartum. And the Bree also includes the infant or the neonate for those first 30 days of life. So what else does the Pre-Perinatal Bundle do? It really encourages physiologic birth, that is birth without unnecessary intervention or natural birth. Talk about physiologic birth in all of those ways. The Bree definitely emphasizes increased attention to screenings and then appropriate treatment based on the results of those screenings and identify of any concerns. And of course, patient voice and choice in terms of appropriate treatment and care. But so I'm talking about both cardiovascular health and behavioral health as two definitive areas that the Bree group identified as areas of need, where there currently is not sufficient clinical care and attention, and there's too much variation across the population when you look at what are providers doing, what are patients receiving. Cardiovascular health and behavioral health are two of those areas. The Bree also really framed up improving postpartum care, looking at postpartum care not as one comprehensive visit, usually around 6 weeks post end of pregnancy, but really at least 2 visits postpartum by, again, that accountable entity or that primary OB provider, really thinking that a visit at about 2 weeks and retaining kind of the more comprehensive postpartum visit at around 6 weeks is the best model of care. That is also what is by ACOG and other kind of leaders in terms of clinical care. And then elevating patient-centered care. So shared decision-making is one tool to do that. But this is really thinking about how do we provide care that truly is patient-centered, it's tailored, it's individualized to the patient and the patient and their family. Questions about that? Then I'm going to move away from the Bree. Okay. Am I talking too fast, Heather? Shalia, am I okay?
No, you're doing great.
Okay.
You're good.
Okay, thank you. So from the Bree work, and again, just kind of in the broader context of HCA's goals around improving health and well-being for the population of pregnant postpartum folks and infants, we started working on our maternal care. So how can we, and I think it was on the slide, but I didn't mention it, back to the Bree really quickly, like what do they do with their recommendations? They do a lot of things. They post them, they share them, they sometimes write peer-reviewed articles, and they also share them back with the healthcare authority. So then kind of our role as the state Medicaid agency and a major, purchaser of healthcare is to look at, uphold and look at the Bree's recommendations and then translate them into our context, into our Medicaid context and our own authorizing environment and figure out how we actually move to implementation. So that is really kind of the path we are on now. And we are calling this the maternal care model. Our goal with the maternal care model is to really incentivize and promote high quality, high value clinical obstetric care that improves perinatal health outcomes and addresses racial and ethnic disparities These are some of our our 5 primary sub goals under that large overarching goal. So again, we're really looking at both utilization and quality. We know from our data, our Medicaid data, particularly in the postpartum period, that utilization of any postpartum care among our Medicaid population is much lower than what we would like to see. It does vary some across MCO, it does vary some between fee-for-service and those enrolled in managed care, but it's really somewhere between like 50 and 60% of our postpartum, post-birth population on Medicaid have any postpartum care at all. So that's definitely something that we are thinking about, and how can we utilize this maternal care model and the other levers available to us to really increase the utilization of postpartum care. But of course, it's not just utilization, right? It's also what is the quality of that care and what are patients and families getting out of it, and how is that in turn reflected in terms of better health outcomes and well-being in the population. We are keenly interested in disparities. We in Washington State, a lot of our overall perinatal outcomes in terms of the national landscape, we look pretty good. We are usually in the top quartile on most of our outcomes. But when you start stratifying those outcomes by demographic factors and race and ethnicity in particular, that is where the true story is revealed. And we have marked and persistent, and in some areas growing, disparities between racial and ethnic groups, particularly those that are particularly furthest from optimal outcomes are American Indian, Alaska Native, and our Black populations. We want to improve birth outcomes overall. That's looking at both baby outcomes and also birth parent outcomes. A very common metric there that I'm sure is really familiar to everyone is the low risk cesarean rate. Our current cesarean rate in Washington, and we saw a slight increase with COVID, which is not totally surprising. I may think we expected that, but it's hovering right around 28%. That is much too high, depending on what source you look at. WHO says that the C-section rate should only be around like 13% or so. A lot of folks in the USA, no, it's probably, upper teens is probably the appropriate target in the US. But regardless, we are well above where we should be in terms of surgical delivery. Our preterm birth rate is just above 8%. But again, it is markedly higher among people of color. And preterm birth also, we saw an increase in preterm birth during COVID. So we want to reverse some of these trends and explicitly and intentionally address the disparities that we see in outcomes. We also want to increase care coordination. I'm sure this is intimately the work that you all do. Our systems are incredibly siloed. We have a lot of barriers, which people are really good about illustrating, all the barriers that we have, and we need to continue to push on solutions from the patient perspective, right? How do we create systems that actually work together synergistically, and where people talk to each other with the patient and family really at the center. And then we certainly want to leverage our full 12 months of postpartum Medicaid coverage with just, I know I already mentioned it, but a plug to this group. I certainly hope everyone is aware that after pregnancy coverage was implemented again last month, and so Medicaid clients, and that is for any end of pregnancy outcome, should have a full 12 months of full scope Medicaid coverage following that end of pregnancy. Questions about this slide?
Beth, I do see a few questions if you want me to ask those now.
Sure.
Okay. Our first question, did you mention how the APC would be different than postpartum for the 12-month pre-perinatal bundle?
Did I mention how it will be different? I think the Bree really focused still on kind of what I would call the earlier postpartum period, and maybe that's what you're picking up on, right? Because I talked about the BRIE really included as a standard clinical practice, like a 2-week postpartum check with that primary OB provider, and then the 6-week. So I would say what's different APC after pregnancy coverage and what's different in terms of the scope we're looking at with the maternal care model is, yes, we like that as well. I think we think there needs to be at a minimum 2 visits post-birth, and frankly, telehealth is a really interesting option for a lot of folks. This is my opinion, but I think particularly for that 1 to 2 week check-in, that I'm very open for that being a telehealth visit if that's what's worked best for families and for providers. And then we are, though, still looking at, okay, but what does the model of care look like for that full year postpartum? And it's a really hard question to answer to some degree because we don't really have good examples. I mean, I think at this point, I could say many states have moved or are moving towards full 12 months of Medicaid postpartum coverage, but we're all kind of doing it along the same timeline. So we don't have a lot of examples from other states around what does utilization look like in your state for your Medicaid population? Like, where are the gaps, right? Like, what kind of care are people accessing, and what do we really need to be thinking about as we're building out the model of care for that full year postpartum? So we're just kind of grappling with that, but it's absolutely on our agenda in terms of the after pregnancy coverage, or otherwise stated, that full year postpartum.
Great, thank you. The next question that came in, how was the patient-centered care measured? Was that through surveys, focus groups? Were parents included in an advisory board?
Oh, you mean from the BRIE? The shared decision-making call out in the BRIE perinatal bundle, I think it shows up at a couple different places in there. I remember specifically around contraceptive care counseling, that really be that a shared decision-making, tool or frame be overlaid in terms of contraceptive care. Was there input on that? The BRIE itself, again, this is just in my experience, but there's really not public input or lived experience input into those recommendations. They really are created by the appointed members of, again, that legislative group. Having said that, all of their meetings are open to the public, but I've attended some of them, and I've never experienced people from, the public or patients attending those meetings. So I do not believe that there really was input around patients or community in terms of that BRIE perinatal bundle. I think that was hopefully that answered your question.
Thank you. I don't have any more right now, so.
Okay. And I feel like I should speed up a little bit, right? Because we got to get to the rest of the agenda and everything today. I probably can, honestly, on this slide, because I have mentioned some of these things already. So again, this is under kind of our HCA work currently on the specific targets for our model. I've already talked about quality and utilization. I've already talked about coordination. That bullet, though, does call out. We are keenly interested in what the care model looks like for folks with a behavioral health concern or identified issue. And that's including both mental health and substance use disorder. And of course, many folks have co-occurring disorders. And so we are looking at evidence, we are looking at other state models. How do we best care for the population of pregnant, birthing, parenting folks who also have a behavioral health issue? We really want to do better at coordinating care between birth parent and baby. Again, this is work that you all do, working with family and both birth parent and baby. How do we carry over some of that coordination and linkage to our clinical care that we are providing? And this is really complicated because oftentimes the pediatric provider or the infant provider is different than the birth parent's provider, right? Not always. So like a family medicine doctor is sort of the example that we talk about and hold up as, well, you know, if you're seeing a family doctor, you can have the same provider for both yourself if you're pregnant and also for your infant. But a lot of people don't have that model. And so what are our levers? How can we really encourage and incentivize coordination between the provider for the birth parent and provider for the baby? And there's some data gaps there too, that we're continuing to kind of peel back that onion and think about how we can solve those, because we don't always have parent infant actually linked in our own systems. Super interested in integrated care, team-based care. Again, MSS is a multidisciplinary team-based model. So speaking to the choir, I'm sure on the value of team-based care. There's also just robust evidence. It's better for patients. They're more satisfied. It's better coordinated. Everything's better. So how do we continue to invest in team-based care? Doulas definitely come up often in the conversation, particularly as an intervention where there's strong evidence that while any person who's lucky enough to have a doula during their pregnancy journey has better outcomes, BIPOC have disproportionately better outcomes or stronger effect sizes. And there are not a lot of interventions that actually show that. And so we would like to continue to invest and support the work that's already happening in Washington around the path to doulas as a Medicaid reimbursement provider. And midwives, we want to increase utilization of midwives, both for folks who want a hospital birth, and they should have that if that's what they want, and also for folks who want a community birth. So I hope everyone attending today knows that Medicaid does pay reimburse for both licensed midwives, who most often are working in community birth, and for certified nurse midwives or CNMs, who most often are working in clinic and in hospital settings, but not exclusively. Before someone says, that's not true. It's not exclusively true, but it's true most of the time. Okay, next slide. Oh, questions. So
I don't see any ones yet.
Okay, awesome, Shalia, thanks.
Of course.
This one I'm totally not going to talk about too much because, so the things that are listed here under goals, we just talked about on the last slide. So I think the point of this is just because some of this seems kind of ethereal still, like, well, of course those are goals, like what are you actually talking about? So here on the right, we have some more specific examples. What will I call out that we haven't? So postpartum care is more than one comprehensive visit. I have talked about that. Systematic and routine behavioral health screening with a validated tool, as well as referral needed and follow-up. That's something that we very much want to include in the model. I talked about physiologic birth, midwives, chronic conditions, definitely. I'm sure folks are aware of, mostly driven by just demographic changes in the pregnant population, that it, you know, every year it is more common that pregnant folks also have more chronic conditions. So we absolutely need to be taking management of chronic conditions into consideration as we build out this maternal model of care. And of course, including that full year postpartum. Metrics. Yeah, I think we can move on. So how is the HCA thinking, right? About, so we have some goals, we have some targets, we have a logic model, like how are we actually going to do this? Well, value-based purchasing frequently comes up in this conversation. All payers, this is true nationwide, this is true across commercial payers and Medicaid payers, value-based purchasing. We are all on that path, and that path continues to move forward. So what is value-based purchasing? It's really kind of a concept. That's how I would frame it up in kind of the most straightforward way. It's a concept around the way that we pay for care. And because, you know, things are never easy and we like to complicate everything, people use all these kind of different other terms when really they're talking about value-based purchasing. So I put a couple of them here, because I'm sure you all have heard these and maybe have been confused about, is that the same thing or is that something different? Paying for performance, paying for value, value-based purchasing. They actually are all kind of the same thing. You know, maybe a health economist would define them differently, but we're not economists. We're just trying to understand what we're actually talking about. So another way that people will talk about value-based purchasing is that it's in opposition to paying for volume, right? And this is kind of the fee-for-service methodology, where you know, a healthcare service or even a visit is provided to a patient, and a certain amount of money is paid for that. And if you provide more of those services or more of those visits, you get more payment. That's kind of the fee-for-service or the paying for volume methodology. And the issue is, there are times when more is better, and there are lots of times when more is not better. And is that really how we want to be paying for healthcare? Or do we want to be paying for healthcare that actually drives better outcomes? Or, you know, in other words, paying for value, or paying for kind of the performance of that care. So how do we plan to utilize value-based purchasing structures? We do. You know, that is going to be our kind of foundational conceptual frame around paying for this maternal care model. And again, the definition of that period will include the prenatal period, labor and delivery, and that year postpartum. And we plan to link payments really to improve performance. That's, again, comes back to what we've talked about a little bit around metrics and reporting. But yeah, linking payment to improve performance by healthcare providers is kind of the high level way that the payment and the value-based purchasing is going to play out. Questions about this? I hope this was helpful and not more confusing, which is possible.
Don't have any new questions yet.
Okay.
Yeah.
I stole this slide from our other, we have like a whole value-based purchasing team at the HCA. And so I did ask them if they had like, do you have any like, you know, clarifying slides on VBP? And so I kind of like this one. What do I want? I do think though, some of you, you know, keen observers are going to say that's the triple aim. Well, what about the quadruple aim? What about the workforce? I always care a lot about workforce. You know, I've had a lot of fun, interesting jobs in my life, and at my heart, I always am a nurse and a direct healthcare provider. So I hold workforce very closely all the time in all my work, and I would argue that workforce should be added here, and this should be the quadruple aim. But how does VBP, you know, do that? Well, it reduces unnecessary, in theory. And if some of you have looked at the research on value-based purchasing, it's not perfect. There are some certainly mixed results and evidence. And overall, the evidence does say that value-based purchasing has greater opportunity to drive better health than a fee-for-service or a pay-for-volume model. Because value-based purchasing can also reward preventative and whole person care, more tailored care, more individualized care oftentimes, because providers can have more freedom and flexibility than they would in a fee-for-service model. And it rewards providers who are providing higher quality care, which I think the rationale there is probably just pretty clear to everybody. Okay, next slide.
We do have a question.
Oh, sorry. The one time I didn't ask, right?
I know,
Yeah.
I was like, of course. So the question is, can you give a concrete example of VBP?
Yes. So VBP example would be, let me use the maternity example. Because that will be relevant. It's just so big and kind of gnarly. But the way a VBP payment could work in the maternal world is that a set amount is paid to an OB provider. And again, our intent is to include all of the provider types that are providing care. This is not just a physician model. So a certain dollar amount is provided to an OB provider to provide care for a pregnant person from initiation of prenatal care all the way through, now that endpoint has to be defined, but let's just kind of leave 12 months of coverage out of it for now because it gets really complicated. So let's just say through 2 or 3 months postpartum. So the provider will be paid a set amount to provide care. And in receiving that set amount of payment, it's very predictable for providers. That also is a strength sometimes of VBP, right? Providers know exactly how much they're going to get paid. That's helpful for them and planning their own budget and expenditures and such. So in receiving that payment, they agree to the required clinical components that are kind of fleshed out within that care, right? You have to provide this many visits, you have to use shared decision-making, you have to do a systematic validated behavioral health screening, you have, right, like on and on and on, there's a lot of the required clinical components. You have to report to us or to whoever the healthcare purchaser is. You have to report to us on the following metrics and how often they have to do that, right? So what would those metrics be? It could be their behavioral health screening rates. It could be their low risk cesarean rates. It could be their breastfeeding initiation rates. I'll just throw in there because I love having a patient reported outcome. It could be your patient satisfaction scores. And so those are all required. And so example of how VBP could look. Did that help?
Yes, that's helpful. And then a couple more questions have come in.
Okay.
How do you determine the value of care that is given and what are the metrics utilized?
How do you determine the value of care? So again, that comes back to what really metrics you choose that are going to be part of the model. And it's never going to be perfect, but you have to, well, and we're living very much in this space right now, like we have to pick, like we have to start making sense. Like in an ideal world, you would want reporting metrics on like a huge number of things, right? From STIs, the ones I've already mentioned, but then add in STI screening, add in, folks who are at risk for preeclampsia being on appropriate preventative aspirin therapy, add in folks who get referred out for behavioral health are able to access those services. Add in a whole host of patient-reported outcomes, right? Like a respectfulness measure and a shared decision-making measure. And so all of those metrics would really point to the value of the care. And in any model, and certainly in the maternal care model, like we're gonna have to choose somewhere between, well, and we don't know, when we look at other states, there's variation here too, like somewhere between, 3 metrics tied to the model or as many as more than 10. But I don't think we've seen any states who have more than 10. And 10 is definitely kind of the high end. So I imagine you're thinking, well, how, is that really, how is that high value care? And I would say it paints a picture, right, that is limited. And this is why choosing the metrics is a critical question.
Thank you. We do have another question. Let me make sure I'm not missing one here. I know that we talked about the VP, does it impact the FQHC encounter rate reimbursement for services, for MSS services?
I know we've talked about VBP. Does it impact the FQHC encounter? I'm gonna say, so this is like a little out of my comfort area, but it shouldn't, I do not think so, no. The FQHC encounter rate is a totally separate ballgame.
Great, thank you.
Yeah.
And it looks like that's the last one for now, but again, if you guys have any questions, please feel free to put them in the question box.
Perfect. Is this my next slide? I'm like so repetitive here. I think I'm just gonna, so what are key considerations? Okay, we talked a lot about metrics. The financial reward and risk, plenty of considerations there in terms of will providers both have opportunity to get paid more? So like incentive payments, or this is, I think in another slide, I refer to this as gain sharing. Again, a concept that has multiple terms to describe it, just to keep us all totally on our toes or totally frustrated. But the other side of that coin is that you can create models where providers also can be penalized, right? So in both cases, kind of the way that works is, again, we're looking back to metrics, and you set thresholds, right? And so you can have a threshold for a gain sharing or an incentive payment. You can also have a threshold for a penalty payment or a risk sharing. So that's just sort of what that means. We want providers to participate. So how are we going to incentivize them? As you all are probably thinking, well, the gain sharing or the opportunity for incentive payment certainly is something that would entice providers to participate. Yes, of course, like we know that's true. And frankly, I think we would like to pay providers more who are providing better care. So, you know, that seems really reasonable. Again, there's this coordination piece. The how to do that, I think we are still, you know, trying to figure that out and what's feasible in terms of a potential metric there around care coordination. And then, you know, I'll just say something a little different with this last point. Like, this work is not a silver bullet to like fix all the holes and all the gaps in our system of care, because there's a lot. There's a lot of silos. There's a lot of lack of communication and coordination. And so we are holding and looking at, like, what is the whole system of care in Washington that's really promoting and supporting this population. And so MSS and ICM are, of course, part of that. So are other models of care, right? Like group prenatal care. You know, is there a way that we're going to try to incentivize evidence-based, creative, innovative models of care that really do drive better outcomes for people? Yeah, okay, next slide. Heather and Shalia, you're hoping like at 1, I'll be done, right?
1 to 1:10 is fine.
Okay, I think so. I'm gonna make that for sure. Yeah, I almost took this out the last minute, and then I was sort of, actually, no, I kind of like this, and I put the source on here. Like if anyone is like, this is so interesting and intriguing, the source for this graphic is wonderful and has tons of great information. I just threw this in here to say, and a lot of these again we have talked about, but when we are looking at our maternal care model under each of these categories, we're having to, you know, come to decisions around, you know, what are the parameters driven by what our goals are, right? So what are our goals? And then what are our decisions in this maternal care model around each of these components? And they're all sort of reciprocal and linked together. It's a very intricate and complicated process to try to figure out how we make this the best possible product that we can. And I'm trying to think if there's anything here that I could call out as a specific example. Some of them for the maternal care model are pretty easy, like the patient population. We know who we're talking about. The episode timing, again, pretty easy with pregnancy. It's pretty, you know, it's pretty evident when pregnancy starts and ends. We certainly, you know, we have 12 months of coverage for the endpoint of our episode timing on the postpartum end. So that's pretty straightforward. Services piece, you know, that's complex. Type and level of risk. Okay, so I can just say something about that. I mentioned how a specific population of interest is folks who have behavioral health conditions or concerns. If we are looking at sort of a separate or enhanced model of care for that population, the rationale for that would be, well, folks who are pregnant and also have a behavioral health condition probably could use additional services and supports. That could be referrals to specialty providers. It could also just be more time with their provider of choice, right? We would like to support models of care that meet people's needs. And so within this model, are we going to kind of have a separate model of care for folks with behavioral health? there would be significant alignment, of course, as much as possible, but would there be kind of enhanced, sorry, so much talking, enhanced services and therefore an enhanced payment for that population. So that's just kind of one example when we're saying type and level of risk. Those are the kinds of things that we're thinking about. Okay, I think that's good. Oh, any questions? And I'm gonna drink water.
Yes. We have a few questions that came in. If you could provide a little bit more detail and expand on how VBP works with prenatal and postpartum care. Looking at providers have an incentive for VBP with diseases like diabetes and high cholesterol. So how would that work with prenatal and postpartum care?
So the person indicated that currently providers have an incentive for folks who have like high cholesterol or other clinical conditions.
Yes, it says providers have an incentive for VBP with diseases like diabetes and high cholesterol. As they get the patient healthier, there are less visits. Less visits equal higher pay per visit. Or another way to say it is if they have a compliant patient, they don't need to see them as much, meaning the pay they receive for that patient goes further.
Oh, yeah, I mean, another way to think, so what that brings up for me, kind of another way to think about VBP is kind of a corollary with an insurance pool, right? Like you as a provider are paid a set amount. For some of your patients, they have less needs. I mean, we could associate that with chronic conditions or just, you know, what else you could grand multip, right? Like someone's having their 6th baby and they've had all healthy pregnancies, healthy term pregnancies, vaginal deliveries. You as a provider under a VBP structure most likely would be getting the same payment to provide adequate, tailored, hopefully better than adequate, high quality, tailored care to that person. And they probably wouldn't need to come in that much, right? And you could kind of adjust that model of care. Now, as long as you're still providing the required clinical care components that are part of that episode or that model, right? And you could also have patients within that population who have significant needs, who want to see you much more often as a provider, who are requiring a lot more care coordination across specialty providers. Let's say this person, you know, has this underlying diabetes or has gestational diabetes, and it kind of gets worked out in the pool, right? That's why I say one way you could look at VBP is similar to kind of an insurance pool. I will share with you also, because I wonder if this was part of your question, a criticism of VBP is that providers can provide less care, right? So I'm thinking back to, it's not a pay for volume model, right? It's not a, you give me this, I pay you this. You give me this, I pay you this. You give, it's a, here's a payment. Here are the expectations here, right? That you have to provide at least this much care. We're going to monitor you with these reporting metrics. We're going to incentivize you with payment. But critically, will say, I think providers are going to provide less care. And so we know that. And so I think our response is, like, we certainly hope not. And we actually think most providers would not, right? Like, they want their patients to do well. And it's a risk. And so then within these VBP structures, what are your levers to like check that providers are not, you know, intentionally providing less care to get the same payment, and, you know, just not adequately treat or care for their patient. I might have gone off on a tangent there, but I sort of felt like maybe that was what you were getting. It's so hard when people just type in questions and then to read into them. But
yeah, especially if you're not able to ask for clarification.
yeah.
So our next question here, if my MSS team doesn't work in the same clinic as the OB, how would the payment piece work to my MSS team? The OB provider now has to reimburse my MSS team?
That's a good question. So we are not looking at the payment for MSS providers or MSS services being directly included in the payment that is going to be associated with this OB clinical model. This payment is really going to the accountable or the primary OB provider, who again is like the licensed midwife, the certified nurse midwife, the family doc, the OB, GYN, or the maternal fetal medicine. So there will be no payment flowing through the OB provider to the MSS provider. The MSS funding is separate, it's carved out. It is a fee-for-service model. We are not talking about moving MSS payment. At this point in time, I should say that, right? Because things change and things can happen, but like, I'm sorry that if that's confusing or I haven't been clear. We're not talking about MSS payment becoming a value-based purchasing payment.
Great, thank you. And thank you for clarifying that. Your next question, could there be providers with a different patient mix because of their specialty? For example, a provider who specializes in pregnant persons with SUD needs. How can we support this provider if their metric results don't look good? Conversely, could there be providers who game the system by only accepting healthy patients?
Yep. I mean, yes. So that kind of goes back to kind of like known risks, right? And we, as part of this project, we have a whole like risk log that we look at and add to and think about, like what are any unintended consequences, right? And so those are unintended consequences that we definitely want to avoid. In terms of, well, then what are kind of the strategies to mitigate those? One example I'll share, because I've already kind of mentioned it, is, you know, maybe for folks who kind of fall under a higher risk pool, and I mentioned behavioral health, but it could also be behavioral health and other kind of biomedical risks. And so if it was structured in that way, and then there's a higher payment associated for care patients who fall, sorry, you guys, who fall under that specified criteria, that would be a mitigating strategy to try to prevent providers from, like skimming off the top, right? From only wanting to take low risk patients because they get paid the same amount. So we don't have a decision on that yet, but that's something that's just an example of how we may structure payment. It's also fair, to be honest. I mean, patients who have more needs, again, typically, there's always variation, as there always is in anything involving humans, but typically patients who have higher risk, higher needs need more care. And if they need more care, we should be paying more for that additional care.
Great, thank you so much for answering those questions. It doesn't look like we have any more right now.
Okay. I think we're like, the heavy content is like pretty much done. So I think we're good on timing. This is just knows where we are. We're just at the tail end of July. The next months are heavy. So if you think back to that graphic that was on just the prior slide with all of those different components in terms of model design that decisions need to be based on, some of them flow somewhat sequentially, some of them are just really iterative. We are going to be very much working on all of those in the next couple of months. You see that here noted as August and September. October, November, we hope to have kind of more detail to share out with stakeholders, get more reaction to in terms of what folks think about the decisions we've made or decisions we're getting to at least. We plan to finalize the model at the very end of this calendar year. And again, this whole stage really through now and the end of the calendar year, we're really in the design phase. After the design phase, here you see 2023, 24. That's really where we're going to move into the implementation phase. So sorry, you guys. And this is recorded. I'm sorry. Whoever's watching this in a recording, I'm really sorry for the coughing. So post the design phase, that's when we really move into the implementation phase. Lots of uncertainty there in terms of what will that timeline look like? Will we need funding? Will we need legislative funding? These are all things that we mention, and frankly, we just don't know until we get through this design phase and actually have a maternal care model that we think we want to carry forward. Next slide. So this is kind of, I'm super happy folks have been asking questions. This is just a time to pause. If folks have other feedback on the goals or the targets or anything that we've shared, if there's additional considerations that you haven't seen mentioned, that would be super helpful. So.
We can give everyone just another minute here if they have any other questions that they want to put in.
This is this this mailbox here, this email HCA maternal care model. We have folks monitoring that and collecting and any emails or feedback that come in through there, and then we will respond to them. So please note that if you're someone who likes to think and process, or even if you're not, if things come up that you want to share with us around this work, please do email them. This is also our website that we have, and the email box is on this website link. So actually, if you mark just the link, you'll also have the inbox. We will be posting information as it evolves on that website. So that's something to bookmark if you're interested in following this work and kind of getting updates.
Great, thank you. I don't, let me double check that. We do have another question that came in. Someone has asked, and they're curious how childbirth education classes will fit into the model as far as collaboration of care goes.
Ooh. Childbirth education classes, collaboration. I don't know. I mean, I appreciate that call out. I will admit, I don't think that childbirth education classes specifically and under, first steps have come up yet kind of in our conversation. So duly noted.
I know.
You have thought, I mean, I think that's, yeah.
Yeah, I attend work group meetings, and so it's always in the back of my mind, but nothing's ever come to where I've, I think with the conversations and stuff, but I think the way that the classes are set up, I've not thought of anything of how it would really fit into it as much, because it is very unique, and it's a kind of a one-time payment.
Mm-hmm. You know what, I would love to sure or help with assurance that anyone teaching childbirth ed and having Medicaid, clients in their groups or even individually are aware of the 12 months of postpartum coverage. That feels, and it just makes me curious if folks who are teaching childbirth ed, because sometimes those folks might be kind of unique in that role, and I don't know what other hats they hold, but seems like a key message that we want to be sure that anyone, doing childbirth education is aware of and sharing with folks and their partners and loved ones. The client and family is aware that Medicaid now has 12 full months of full scope coverage postpartum. So I guess that's an ask I have of this audience, and if you can help spread that word or reach that population, or I guess Heather, for you too, right? That to me, that's a good, I mean, it just came up for me in the person asking the very good question.
I've got it noted. That's, yeah, I hadn't thought of that. Reaching out to those that probably aren't on the different Gov delivery messages. So thank you.
And it looks like that's all of the questions.
Okay, I think this is the last slide, right? This is like a thank you slide. All right.
Thank
Well,
you
then,
so
thank
much.
you. No, thank you so much for having me. And
Yes, thank you.
yeah, I'm gonna drop off because I have another meeting, so I can't stay for the other updates.
Right. Thank you.
Okay, bye everybody.
Thank you so much. Have a good day.
Okay, now it's the time for the first steps MSS and ICM program updates and reminders. And as you can tell, Shalea's back. So
Yes, I'm back. So you guys can resume emails to me if you'd like. Just of course, anytime you guys have questions or concerns or anything, please reach out. So I am back now. Also with monitoring, we just wanted to make a note that we kind of took a pause on that while I was out and some other stuff came up. So if you haven't heard from us and you sent us materials or you sent us, a correct vaccine plan and you haven't heard from us, we're going to be starting back with those here soon and hopefully kind of wrapping up the ones that are in progress over the next month or two. And then we still do have, I guess now it's kind of a continuous monitoring. We still do have some other requests monitoring that we'll reach out into as well. So we apologize for the delay, but we are getting back into it now. So, and again, if you have any questions about that, you can email us.
And an update about the telephone audio only visits and billing. The MSS and ICM billing guide was recently updated July 1st with a couple new, well, I guess one new place of service and different new definitions for place of service 0, 2, and 10. And that's when telemedicine, telehealth services are provided, either whether the client is outside of their home or in their home. And then there's also when telephone audio only visits are provided, it does require the modifier 93 on the claim. And again, you need that HD modifier as the primary modifier. The 93 can be after the HD, or if you have an HD TG, after there, it can be secondary, tertiary, it doesn't matter. Just need to make sure that the HD modifier is the primary modifier on the claims. I believe most all of the billing guides for the Healthcare Authority are going to be updated for August 1st. Does also include the MSS and ICM guide. So for the month of July, there was a little bit of a telehealth blurb in regards to the audio only under the MSS section and under the ICM section. And then August 1st, it's going to have blanket language that's being used in all of the guides in regards to telemedicine and telehealth, kind of at the beginning, and it's going to encompass all both MSS and ICM. And then at the end for billing, it also gives the definition of which place of service code to use. And then I believe within that, it also includes the modifier of 93. And then on the website, the Healthcare Authority's website for the billing guides, there's also now going to be a specific, or actually it's already there, a specific telehealth section within. So if you go on the billing guide website, scroll down to the T's under telehealth, it lists some helpful guides and then policy. And then it also lists out the codes that are allowed for audio only visits. And if you click on that, it's I think it says effective August 1st planned. And as far as I've heard, knock on wood, the plan is still a go because this was supposed to have taken place July 1st. So under that, it does have all of the MSS codes except for the code for group, because group is not allowed via telephone audio only. And then it also has the ICM code, and then it has marked yes that it requires the 93 modifier. So that guide will probably be published, I would assume sometime this week, since it does go into effect August 1st. They generally like to have them out a couple days in advance. So be watching for that. And then we put on here the required training for nurses. I happened to get a Gov Delivery message from Department of Health, just kind of reminding of required trainings. I believe behavioral health specialists also may have some requirements and other provider types. And so it was just something that came through recently. So we just thought we'd put it on here to remind everyone of the required trainings. And so make sure, because these are DOH requirements, they're not Healthcare Authority requirements. So if you are licensed or credentialed, make sure that you're keeping up to date with what's required of the Department of Health, because we want to make sure that your license and your credentials are remaining up to date so that you can continue to be an MSS or ICM provider. Whoops, sorry. And then also, as Beth said during her presentation, the after pregnancy coverage APC started last month. I believe I haven't heard of any huge issues, so I believe it's going pretty smoothly. So what that is when somebody has a pregnancy has ended, and as Beth mentioned it earlier too, it doesn't matter how the pregnancy ended. You need to encourage people to get onto the health plan finder and update the delivery date, because then what that does is it lets the system know that they need to move that person into the APC so that they get that full year of continued coverage. So there is a new website here, and I'm hoping everybody was able to access the PDF in the chat. And then, like I said, it will be sent on the email with the link to the recording, but you should be able to click on these hyperlinks within the PDF. And if you want to look at the websites now and you're not aware of what the address website address is, if you go to hca.wa.gov and just type in APC or after pregnancy, the website should pop up for you. But right now, the main thing is to remind clients to update their contact information. And that's kind of, even if they're not part of the pregnancy eligibility, it's almost for everybody, because eventually the public health emergency, right now it's continued to the middle of October, and we're not sure yet. So I think we've got another month to go before we'll know if it's going to continue again for another 90 days. So definitely trying to get ready for that as well. So make sure that when you're talking with folks that they update their information, especially if they've moved or there's been any changes in the household. And then I wanted to let you guys know there's a change coming to the chemical using pregnant program, and it's a name change. I've been working on WAC update to make it gender neutral, because currently right now the program is officially called the Chemical Using Pregnant Women Program. And next month, I think a month from today, actually, the public hearing for the WAC to change some information, especially the name, will be taking place, and the new name will be the Substance Using Pregnant Person SUPP program. And big news, Multi-Care Good Samaritan Hospital, July 19th has opened up their CUP, soon to be / SUPP program. So we now have 5 hospitals in the state of Washington that are providing services to pregnant people who are needing some additional support and hospitalization with their substance use and pregnancy. One update that I forgot to put on there, and then thank you to someone who asked. So the monthly client list has been on hold. We had an employee retire, and we were working on hiring somebody to fill his position, and we finally have found somebody, hired somebody for the data position. So hopefully once she's kind of has her bearings and gets more into the system and learns the system, we can start getting the reports out soon. So I'm not sure exactly if I'll be getting a list out in August, possibly, but what will happen is once I get the monthly MSS client list sent out again, I'll probably do it for the current month and the month prior so that you guys can start reaching out to clients who are newly identified as pregnant. It looks like
We do have a few questions, Heather, if you'd like me to read those out loud.
I saw the one I'm trying to about the notification from HCA and it states effective 7/1. I'm wondering if that was in regards to the telephone visits. So if that is what it's about, 7/1 is when MSS and ICM are requiring that you use for telephone audio only visits to use place of service 0, 2, or 10. And I believe it's also for telemedicine visits for dates of service prior to July 1st so that we can pull accurate data. We need you to continue having billed with the directions that we had given previously, where you use the place of service as office or FQHC clinic. And the modifier of CR when it's telephone audio only. For dates of service July 1st and later, use the 93 modifier and the 0, 2, or the 10 place of service code. And the update that's going to take place for August is pretty much the same. It's just the guide's going to have a little bit of a different look to match all of the other guides that Healthcare Authority puts out.
And I can answer the next question about the required trainings that you mentioned on this slide. Just to clarify, these are trainings required by Department of Health and not Healthcare Authority, but if you download the file for the presentation, those links are clickable. So if you click on the suicide prevention or the telemedicine, that will actually take you to the website that gives you more information about it, as well as how to take the training.
I believe on Department of Health's website, there's a specific training for telemedicine for behavioral health specialists, if I'm remembering correctly. And a lot of these trainings are virtual. And so that training, it's been a couple of years, but I was able to take. So I believe some of the trainings, they're not limited to just that provider type. So if you have, let's say, community health workers in your clinic who are interested in getting some additional training, and you've gone through those trainings online, definitely please share that with them. Okay, and then there's a question of any chance that MSS or ICM will have a rate study and possible increase in billing. Every year I submit a concept paper and then we see if it moves on to a decision package. So we will hope that it will be something that will move on, and maybe this year will be our year and we'll be able to get some movement on unit increase and rate increase. Right, any other questions? And as always, this is our anticipated quarterly webinar schedule. I had planned on April, which then got moved to May, to do a limitation extension request on how to enter them directly into the system. Unfortunately, I got COVID when we were to do the presentation, so got rescheduled. And then July, I was asked if the maternal care model could be discussed, which I think it's perfect timing for that. So hopefully October, we will be doing a presentation on entering limitation extension requests directly into the Provider One system. And then, as always, any questions, please reach out to Shalene myself at thefirststeps@hca.wa.gov email. Or if you have our direct emails, send that to us as well. Definitely here to answer any questions or provide any assistance that we can.
And thank you so much, everyone, for joining today. We do appreciate it.
All right. And so we'll give you guys a little bit of time back. And we hope that you all are able to stay cool. At least on the west side, we're getting some heat that we're not used to. I think it says 94 outside of my house right now. So
Wow.
nice.
Very hot.
Yes, thank goodness for air conditioning. So we hope you guys all have a great afternoon, and if you need anything, reach out to us, and otherwise we will see you in October.
Bye, everyone.